chronic management of seizures, right? So it's nice to think about non-pharmacological management and pharmacological treatment. Non-pharmacological, for all of them, we need to be recording dates, times, and events around the seizures. So you want to get a seizure diary. We want to provide and advise on getting a medical alert bracelet or some form of kind of easy way to let people know that you've got epilepsy. You need to do family counseling, and this helps to provide support for the patient, also helps to decrease stigma and helps them to look after that patient better. And again, advice on things like alcohol use, sleep hygiene, and adherence to medication. Pharmacological treatment, so the kind of pharmacological arsenal that we've got available to ourselves is lamotrigine, levetiracetam, carbamazepine, and valproate. And then going lower down on the list is phenytoin. These medications are kept there, the top four are kept there because those are within the guidelines for initiating therapy. Phenytoin is on the list, but it's not on the initial table for initiating phenytoin. We'll speak about that in a bit. Generally, we want to aim for monotherapy. The principle is to start on the treatment, titrate up safely, and each one has their own kind of titration approach, and get them up to there's normally a therapeutic level that's recommended, but we want to increase to a place where we are optimizing, preventing seizures and optimizing our quality of life. And then the idea is to titrate and increase kind of at least 2 weeks apart of those changes. So this is very well set out in the standard treatment guidelines chapter, and I'll have pictures of that too, but kind of just some of the extra notes. So lamotrigine, so this is the preferred first line for all cases, basically, with a few caveats. It requires slow, careful up titration. So it is more used in low-risk seizure type epilepsy. So distinguishing between high-risk and low-risk seizure type epilepsy. High-risk seizure type is if a person has frequent seizures, they've previously had hospitalization for seizures, and if they've had previous status epilepticus. And to remember with lamotrigine, the main side effect here is Stevens-Johnson syndrome. So Stevens-Johnson syndrome can look like this. It can start as a kind of a skin rash, a few kind of lesions, but then it can rapidly progress to oral to mucosa, and it can even look like a severe burn, basically. Levetiracetam, so this is kind of in the newer guidelines. It's exciting to see it's in the standard treatment guidelines. I did phone our pharmacy, so we do have it at CMH. It'd be interesting to see how it's been kind of rolled out and provided at other settings. This is better for high-risk epilepsy types. The side effects are generally neuropsychiatric from what I could find. And here, for the dosing, you're going to initiate it at 250 milligrams orally, 12 hourly. Your therapeutic dose is basically one titration level up. So 2 weeks after your initiation, you can titrate up by 500 milligrams already 12 hourly. So that gets you, you can immediately get to your therapeutic dose, and your maximum dose of levetiracetam would be 1.5 grams 12 hourly. Carbamazepine, important to remember that if a person is on TLD, you need to double the dose of dolutegravir. Because it has drug-drug interactions and makes it be less effective. Remember also that carbamazepine is sometimes used for neuropathic pain. So it's not just if someone's on ARVs that you need to worry about. Not just if someone's got epilepsy and you need to worry about the ARVs. It's also about any cause for being on carbamazepine that you need to look for it. For carbamazepine, you'd initiate at 100 milligrams 12 hourly. Then they talk about titrating up between, at weekly intervals, you titrate up by 100 to 200 milligrams as your daily dose, and your usual maximum dose is 600 milligrams orally, 12 hourly. Valproate, we've spoken at length about the pregnancy concerns. You initiate here between 200 and 300 milligrams orally, 12 hourly. You titrate up every 3 days to 2 weeks, so you can use 2 weeks, and your max is 1.2 grams orally, 12 hourly. Again, phenytoin, not recommended as an anti-seizure medication to initiate a patient on. However, provision is made for it to be continued in adults who are already on it and already well controlled. But if it can be made to switch across to a different anti-seizure medication, if a patient is receiving a higher than usual dose of phenytoin, then there should be therapeutic monitoring. The usual dose, kind of initiation and maintenance, is 300 milligrams orally, but should be titrated to the person's body weight of their lean body mass, and there's a risk for gum hyperplasia and cerebellar damage. So something that just kind of was brought home to me was I once had a patient that presented, and I said, how can I help you today? What's happening? And he said, no, he's worried because his teeth are shrinking. And actually, when you go and you have a look back, this guy's been on phenytoin for a long time. One could definitely make the case that he should have been changed onto another anti-seizure medication, but he'd had quite severe gum hypertrophy. And then also phenytoin toxicity and cerebellar damage. It's an interesting one to see just on physical examination. The person can present with a kind of atonia, imbalance, and they may have nystagmus as well, especially in the acute phase. So the anti-seizure medication recommendations by the seizure types or the epilepsy types, basically all of them get broken up into people that can't have children and people that could have children, right? So for the focal seizures, you've got your first line would be lamotrigine for both population types. Your second line, you can consider carbamazepine in patients that in people that can't have children, or levetiracetam, and your second line you do levetiracetam. Again, we spoke about at the end there, avoiding carbamazepine with HIV, obviously here in all of the populations, we're going to try to avoid valproate. In generalized epilepsy, remember you've got the motor types and you've got the non-motor type, kind of rough breakdown. So in your tonic-clonic seizures, again, you break it down to people that are unable to or can't have children, and then women of childbearing age or potential for having children. Again, your first line treatment here would be your lamotrigine or your levetiracetam. And again, we see that idea about low risk versus high risk for those treatments. And then your second line treatment, then again, you see for your tonic-clonic seizures would be whichever one you didn't start with, or valproate. But in the patients that valproate is contraindicated in, you then consider your combination therapy with lamotrigine and levetiracetam. In generalized seizure, in generalized epilepsy, the absence type seizures, here again, we've got our two different populations. This is one of the few ones where, or as I found, kind of the only one where valproate would be your first line. When you've got adolescent boys, men, and women not able to have children, valproate would be your first line drug here. So in absent seizures, and remember, this is one of the difficult ones to kind of diagnose. Then lamotrigine is your second line, and then in people that can have children, lamotrigine and levetiracetam is your options then. The general principles, we want to assess the response to our dosage changes at each visit. We want to assess what triggers are occurring. We want to see if there's any obstacles to taking the medication. Is it a big pill burden? Do they need to have a reminder to take it? Kind of a whole lot of aspects. Just this, it's the same as, if not kind of more important than all medications, important to do this. We're going to be titrating up with kind of the safest one being at least 2 weeks between your changes. And you always want to check for alcohol misuse and your social support and safety at home. So if someone's already on an anti-seizure medication and you want to try something else, or you want to kind of move them onto something, or perhaps they're on phenytoin and you want to shift them onto your lamotrigine, then what you do is you mustn't be in a rush and do a whole lot of fancy things. It's quite well described here. So you keep your primary medication on board, you keep the dose the same, and you start your new medication while they're also on that. And there's different ways to do that depending on which seizure medications are happening at the same time. You titrate that up over the safe period until that's at a therapeutic dose. And only once that new medication is at a therapeutic dose, then you can start weaning. And you wean this over 6 to 8 weeks, right? So you need to kind of make sure that there's a good control of the seizures throughout. So this goes more into the lamotrigine monotherapy. So I didn't speak about the initiation of lamotrigine at the beginning because this has there's a bearing on what other treatment there might be if it's add-on therapy. So in general, lamotrigine, your week 1 and 2, you're going to start with 25 milligrams daily, obviously warning your patient about Stevens-Johnson syndrome as a possibility. And then for week 3 and 4, you go to 50 milligrams daily. You then increase you titrate up by 50 to 100 milligrams every 1 to 2 weeks, and your maintenance dose is normally between 100 and 200 milligrams a day. If you've got lamotrigine add-on therapy, Then what you need to do is you need to consider, is this patient on any inducers, like lopinavir, ritonavir, atazanavir, ritonavir, phenytoin, carbamazepine, or phenobarbital? Here you would start on 25 milligrams daily, then move to your 50 milligrams daily, and again, your titration strategy is similar. Then, if you've got a patient with a regimen already has anti-seizure medication that induces the glucuronidation of lamotrigine, you're going to start at 50 milligrams daily. So just note that it's different. The other ones were 25 daily. So you start at 50 milligrams daily, and then you week 3 and 4 you go to 100 milligrams in 2 divided doses, and your maintenance dose is higher. And here, this is where lamotrigine and sodium valproate don't play well together. So if there's therapy that already contains valproate, regardless of other medication that's occurring, you want to start at 25 milligrams on alternate days, okay? So you're starting at a very slow aspect. Then after your first 2 weeks, so week 3 and 4, you then do 25 milligrams daily. And then after that, you're going to be titrating up by between 25 to 50 milligrams every 1 to 2 weeks. So the way that I've remembered this is that you talk about sodium vol slow rate. So you know that you're going to go up slowly on this because there's an increased risk of well, you're not going to control your seizures so well. Right.